Hi, I'm Deanne Birch, lead for the Hep C Later programme. Welcome to our first mini podcast exploring examples of best practice in the National Hepatitis C Elimination Programme. Today, we'll hear from David Byrne, Cheshire and Merseyside's ODM manager, to understand how his team have worked tirelessly to reach as many people at risk of hepatitis C as possible and explore new ways of working. So, David, tell us about your ODN and the services you integrate with.
So my name is David Byrne. I'm the Cheshire and Merseyside Hepatitis Operational Delivery Network Manager. We cover a population of about 2.1 million people in Cheshire and Merseyside. And our goal is to eliminate hepatitis C by the WHO deadline of 2030. We have a team of around 15 core people at the hub, and around another 15 based in spokes that are specifically focused on hepatitis C.
Who are the key services you and your team engage with?
So we work with all our addiction services. So those are Change, Grow, Live, We Are With You, the Westminster Drug Project, and Merseycare to ensure we can achieve elimination. We do that in lots of innovative and different ways, and in a very integrated way. We also work with our criminal justice system, and of late we are starting to work more with our general practice partners. We also work with our emergency departments around the patch to support emergency department testing as well as now coming on some maternity services.
So tell us about your key findings so far in working towards microelimination.
One of the things we've realised quite over the last several years is that our presence in general practice is limited within the program. So we are incredibly good in the elimination program of working with our partners in addiction services. We're incredibly good at working in hostels and with our homeless populations. But one of the areas where we really felt that there was areas for improvement was in general practice. People to try and identify people with hepatitis C who may never engage with health services because they see themselves as very well, or they may have barriers that stop them reaching into secondary care. So what we decided to do was that we needed a way of identifying those people in primary care. And along with our partners within MSD, and along with our partners at NHS England and our partners at EMIS, we worked with EMIS to create a bespoke program in what they call EMIS Pathway. An EMIS Pathway allows us to reach into the GP record. It allows us to identify people that are coded as hepatitis C not resolved, and also identify people with risk factors that don't have a recorded test on the GP system. And then it helps us to engage those people.
The EMIS pathway tool sounds very promising. What have your key results been using the tool?
So we worked with the EMIS Pathway to develop that. We rolled out to the first 3 pilot sites. Of those first 3 pilot sites, nearly 80% of the people that were coded in primary care that were hepatitis C not resolved, actually we had treated. So we knew that was a coding issue. And then there were a few other people, patients in that group, where we were able to offer testing. So they were coded as hepatitis C not resolved. We offered those testing, and we were able to identify some positives in that and offer them treatment. And these were people that would usually never have engaged until they became really, really sick. So they were people who were living normal, in quotes, very healthy lives, and wouldn't have seen hepatitis C as a risk. So we were able to identify those and offer them treatment.
So for those ODNs or areas who may not be as far ahead as you in microelimination, what would your advice be?
My advice to other ODNs is to engage with this pilot. It has huge benefits in your area. 1, to get coding correct. 2, to identify people that you may not have been able to identify otherwise who have hepatitis C, and also to test those people who are coded as having hepatitis C who may not have it, and get that coding right in primary care. And also it gives you the opportunity to find people who may be at risk of hepatitis C and to offer those testing, why testing is so freely available to us. It is a lot of work. It requires resource to do that. But while we have resource within the programme, it is a very, very worthwhile opportunity. I often say the best way to describe Pathway is it is not perfect. It is not a panacea, but it is the best we've ever had to identify patients in primary care with hepatitis C since I've been involved in this programme. We're happy to support any ODM that wants to engage Pathway in their area and share our learning from that process. And what it's done with us, it's made us realise there are more areas we do need to reach into. So, for example, of the 2 positives we identified, they could have been picked up in maternity services many, many years ago if there'd have been routine testing available. And one of the things that's pushing us to do now is to engage in a pilot for maternity testing and to try and build that evidence base to ensure people do get routine access to hepatitis C testing in maternity services, something I know is a goal of the programme and of the national team. So don't be scared. It's a lot of work, but it can pay off, and it can allow access to treatment for people who would never normally gain access to that treatment.
Thank you, David, for sharing your insights and your work to date. If you'd like to access more resources or best practice across the national hepatitis C elimination programs, visit www.hepsilator.com.